Yes, of course. It was a phase 3, yes, as you said, randomized, placebo-controlled trial comparing Upadacitinib 2 doses versus placebo. It consisted of 2 52-week periods, and it's only the first period I report upon because the second period is still going on and will finish in March 25. So in this first year, so 428 patients were randomized to be treated in a 2:1 ratio with Upadacitinib 15 milligrams. These were about, I think, 209 patients in that group, 107 patients in the group of 7.5 milligrams Upadacitinib, and then 112 patients in the placebo group. The placebo group got a 1-year taper of steroids. This is, in fact, the standard of care for giant cell arthritis, steroids for 1 year. The 2 UBA groups got 6 months of steroids as a background therapy. And then after 52 weeks, the primary endpoint was the proportion of patients in the different treatment arms in sustained remission. And this turned out to be positive. UPA 15 milligrams was significantly better than placebo. UPA 7.5 did not reach significance. Were very close, but it didn't reach significance. So it was somewhere between placebo and UPA 15. And also many secondary endpoints like total, so cumulative steroid dose, the frequency of relapse, they were all met. So UPA met all 9 out of 11 ranked secondary endpoints also. It was a positive study. It couldn't be more positive. Not really. Well, maybe a positive one that we were in fact surprised of the fact that we had so few side effects. We had only 2 cases of major cardiovascular events, but they were all in the placebo group, so none in the UPA groups. The venous thromboembolism were also very well balanced between groups, and there were also no overfigure of cancer. So there were, although these were elderly patients, a mean age was 71.5 years, there was no problem with MACE or VTE or cancer. Well, it's not approved yet, of course, but we are definitely looking for even better treatments, because the current treatments, this is steroids and tocilizumab, an IL-6 inhibitor, they can perfectly stop the clinical picture. When you block IL-6 or when you give them steroids, the acute phase response disappears and the patients feel well again. They don't have these PMR complaints anymore, headache goes away. But what is more and more obvious now from studies from Connie Wyand from the United States, and also from PET studies of Peter Grayson, or yesterday there was also an abstract of Maria Sid's group from Barcelona, where she incubated temporal artery biopsies with tocilizumab, and apparently half of these temporal arteries, they found another way to get inflamed. So we are definitely looking for better drugs to treat GCA, with fewer, of course, with fewer side effects as steroids, but also with a deeper effect on the vasculitis itself. Because we have the impression steroids and tocilizumab, they suppress the disease, but don't cure it. And I think for curing, if we can speak about that, this disease, we have to get rid of that smoldering vasculitis, which is there in steroid or tocilizumab treated patients, and which can lead eventually to aortic dilation. And therefore, I think because upadacitinib also interferes with interferon gamma, and so it not only interferes with Th17 lymphocytes, but also with Th1 lymphocytes. And I think these are the cells which play a major role in that, in vasculitis. So this is a potential. Of course, it has to be looked for in that second year period, and in maybe other studies to come, where we look at imaging and re-imaging these patients to see if vasculitis really has gone. But from a theoretical point of view, I think that because it's not only tackling these Th17 cells, but also Th1 lymphocytes, that it may change the treatment of this disease. I am quite involved in positron emission tomography studies in giant cell arthritis. We started that more than 25 years ago. And we recently published a study in the Annals of Internal Medicine in October last year, where we followed more than 100 GCA patients prospectively every year with CT scan of the aorta. And we correlated that to the PET image at diagnosis. And the hypothesis was that the patients who had their aorta inflamed at diagnosis would get dilatation during follow-up. And this appeared to be the case. Now, the next thing that we will do is studying another series of patients, but instead of CT scan, yearly PET scanning, to see if this smoldering vasculitis I was talking to you about, if this is really the force that gets these arteries dilated. For tocilizumab, about 15 milligrams was able to lower the dose of steroids, which were needed at first year of treatment, dramatically, I would say, from 2,900 milligrams to 1,600 milligrams only. So this is, I think, a major advantage.